Thank you everyone for giving me this opportunity. It is always difficult to talk about ACL reconstruction after Dr. Anand Joshi's talk. My talk is more basic and less elite, but at the same time, I'll try to bring my points for the discussion. Number one is right surgical technique starts with the right indication. And for us, a symptomatic instability like frequent giveaways, feeling of popping out of the knee is the right indication for an anterior cruciate ligament reconstruction. We basically divide ACL tears into two types. One is the low intensity injury. They have the slightest twisting injury and they get the ACL tear. These are the patients who have weak core muscles, flat filled, knock knees. They have generalized ligament laxity, especially hyperextension at the knee. These are the patients who have very narrow intercondylar notch. This is a typical patient. You can see flat feet, valgus knee, waddle in the gait. And we are extra careful in these patients because in the rehabilitation pre and post-op, because here we'll focus more on core strengthening right from the foot intrinsic to the spine for better results. And the other type is the high intensity injury. The usual contact sports, the footballers or other high contact sports, usually their knee may be straight or varus, they have a wider notch, and they are usually frequently associated with extra articular corner injuries, surely because of the intensity of the trauma. So we start our approach with the examination. We examine the gait. We see if the knee is in hyperextension, then my tibial fixation angle will change. Because if I fix the tibia in flexion in a hyperextended knee, then I will get a flexion deformity and patient won't be happy. So in that case, we just fix it in a 0 to 5 degree of knee flexion. We do the routine examination of knee, meniscus tests, the Lachman test, anterior rubber, extra-articular ligament laxity, and rotational instability test. And we have contraindications. A swollen knee, a painful knee, a knee with skin bruises, that means there is some deglowing of some extra soft tissue injury, is a contraindication for us. And a doubtful clinical instability where history and examination doesn't match the MRI finding is a contraindication for surgery for ACL. We pay a bit attention to instrument and implant, and this is important for a beginner. If possible, have a sterile camera. It will avoid the problems of fogging. Keep a arthroscopic wand ready because sometimes errant bleeders can discourage a young surgeon. And usually I always keep a saw with the blade. In case something goes wrong with my SAMITI graft, I can take the bone patellar tendon graft. Always keep sharp remus because a blunt remus can cause a lot of heat necrosis and cause widening of tunnel post-op. And a proper jig, which is non-defective. Many a times we use this Indian implants where the jigs are not right and properly angled and not in the right direction. It can give you frustration intra-op. Implants, always keep everything at hand, suspensory fixation, and when you use variable length loops, always keep two, because many a times these are difficult implants. If you get stuck with something, you are stuck in the surgery, so always keep a spare. We keep suture discs, bioabsorbable screws if the graft is extra long, and always suture anchors in case we need to repair the corners. We have replaced our Ethibond with the fiber wires number 2, and we do use fiber tapes in case of small grafts to reinforce the graft. Our choice of implant is suspensory fixation on both sides, especially with the variable length loop device. We have not had any problem with the suspensory fixation even in tibia, and this is our technique of choice. So steps, first is the examination under anesthesia. We examine the patient, laxity test, anterior-posterior, sideways laxities, rotational laxities. This is important for us because that is what will decide our surgical steps. The next comes the position. We always make sure that the knee can be hyperflexed so that the foot is supported on the table, because we always hyperflex for femoral tunnel, and we just keep a small simple side support so that for the meniscus distraction for the valgus, we do not use the hanging, the usual table that supports that which people use. My 3 favorite instruments for ACL reconstruction is number 23 blade, which I use the backhand of to scrape the muscle of the graft. my straight artery, which expands my portal so that my scope doesn't get stuck. And without a mixture, I can never operate an ACL reconstruction. We start with a soft spot incision, expand the skin portal with the straight artery so that my scope doesn't get stuck at the fat pad or anywhere. I put my trocar and cannula, and then starts the arthroscopy round. Start with the patellofemoral joint. I just go back. The moment I am in the intercondylar notch, I like to debride. This is a mid-substance tear. And that is why I like to debride the stump to prevent cyclop formation and impingement pain. I slightly excise the fat pad at the lateral portal so that when we hyperflex the knee, we don't get obstruction of the view, because the amount of view which you get with a hyperflex knee is very small, narrow, very restricted. I don't want to get stuck there. And then the usual arthroscopy round, examine the medial meniscus, the lateral meniscus, and then I debride the femoral part of the ACL femoral stump adequate enough so that I can see the footprint and the stump. Here, since it's a mid-substance tear, I like to excise whatever redundant loose tissue is there, because I don't want it to give me restriction of flexion later on. Then comes, Then I make entry point for the femoral tunnel right at the native stump of the ACL, clean up the end, just clean up that hole so that I can visualize it when I'm starting my femoral reaming. Then comes the step of harvesting the graft. My incision is 2 centimeter medial and inferior to the tibial tuberosity. Usually there is a horizontal bleeder in the middle or the inferior part of the graft. That tells me I'm at the right spot. And then I palpate the pes censorinus with the finger, clear of the tissue there. Usually the gracilis is bulbous, and between the two, gracilis and semity, with a 15 number blade, I make an incision, expand it with the stilis, and then with a mixture, I loop the graft in out carefully, seeing that I'm just taking semitendinosus by looking at the fibrous insertions of the semitendinosus, and then I loop the graft in. These are, you can see this. There's a better video here. I loop the graft, and then I excise the stump of semitendinosus with the sleeve of periosteum, which according to me helps better healing. And then I make sure I spend extra time to see that I remove all the fibrous insertions of semity. I spend a little extra time here because I don't want to get stuck with a stump amputated graft. So unless and until I am clear that all the fibrous bands are excised, I do not bring my stripper in. Once that is so, I bring my tendon stripper in, and it's fairly easy. It is the time where I keep the knee slightly more flexed, and it's directed toward the ischial tuberosity. And here comes my graft. I use simple techniques. I just clean up with the back of the 23 number blade. I clean up the muscle. Then I simply fold the graft into, and then I use an artery forceps and a mixture to hold the graft rather than the clamps. I'm more comfortable with that. Then goes the stitching. With the fiber wire, the advantage is I can go as long as possible because fiber wires are well tolerated intra-articularly. We always have, so that's fine. Ethibond sometimes can give rise to problems intra-articular. So this goes the stitches, both sides. And then I fold the graft and measure. Here the graft measures 7.5. I will be using a tape because less than 8 I like to use fiber tape, which is it can be open to debate whether it's right or wrong, but I usually use if it's less than 8. And then I just tension the graft on simple clamps by manually giving pressure. I don't use any extraordinary device, and then cover it with the antibiotic soaked gauze paste. Then comes the arthroscopy round, making tunnels. I make a needle entry with medial for accessory medial portal, not too medial to scuff the medial femoral condyle, but medial enough to get a right trajectory for my femoral tunnel. Again, here after making incision, I dilate the incision so that my reamers or instruments don't get stuck. And then comes this retro drill pin onto the old marked femoral tunnel. At this point, my knee goes into complete flexion. You can see this. I'm holding onto the retro drill pin and my knee goes into complete flexion. And then this retro drill pin is drilled all the way to the far cortex. Here, the advantage of this retro drill pin is I don't need to ream it with endoscopic reamer. It's usually between 35 to 40. And then I am reaming on top of that. If it's directly, I'll be reaming with 7.5 millimeter reamer. All the time when this is happening, someone is pushing saline with a 1 liter bottle so that I can get a clear vision, because many a times seeing it clearly is a challenge. So I will drill it to 25 millimeter because I have a good 40 millimeter tunnel. And then I will pass a passing suture and then bring back the knee in the flexion. Then I'll clean things around the tunnel so that there are no bone dust or anything left there which may obstruct my graft. I debride a bit of tibial stump only so that I can see the footprint, because here it is a mid-substance tear. There is some debridement, but otherwise we try and preserve as much of ACL stump as possible. Then comes my jig. Now, it's around 55 to 60 degree angle which I keep, but in coronal plane I am not very particular because our femoral tunnel is independently drilled. It is not very important according to us to have a coronal plane direction rigid parameters. And then it goes, the drill bit pin goes inside. All the while I am looking at the, and here is the exact center of the stump. The reamer goes in. If it is more than 9 millimeter, then I ream it sequentially. First I ream it with 6 millimeter and then directly 9 millimeter. But since it is 7.58 here, I don't need to sequentially ream it. Again, clean up a little bit. And then once the reaming is done, I try to clean the area around the entry point of the, so that my graft is not obstructed in any way. And then my passing sutures comes through the tibial tunnel and my graft. And then I debride, clean up the little bit, whatever bone dust, bone saw, the little soft tissue, loose pieces, I clean them up. Then comes the graft preparation. We mark, since it's a variable loop device, since it's a 40 millimeter of femoral tunnel, we'll mark it there. And the graft will mark at 20 degree. Here I have not shown the fiber tape here because the video was slightly corrupted, that part of the video. And here this is to be at equal end. That is very important. Both the graft ends should be at the equal end. That is, otherwise you will have mismatch. And here our graft is ready for insertion. Then comes the graft passage. The graft goes through the femoral tunnel. Once it is the endo button locks at the femoral cortex, I cycle the knee so that the femoral endo button is fixed onto the cortex and it doesn't dislodge. This is an important step for me. I don't want it to get dislodged. And then the graft is pulled in while the scope is looking at the graft. You can see here the fiber tape. The graft goes in as the designated marking point. You can see it's clear of all the edges. The graft has no impingement right now. And then We fix it at the tibial end. Here we keep usually 15-20 degree of knee flexion. For us, it's enough, and we have not had any problem with that. So once the tibial fixation is done, we retighten the graft at the femoral end using the variable length loop device. This is the main advantage of the variable loop. And we have not found a need to put a bias screw unless the graft is very long. And now you can see the graft is well fixed, stable, and without any impingement on extension. Now the knee will go in extension and you will see that it's cleared off. We remove the bone dust. The knee is in extension. There is no impingement for whatsoever from any side. And this is the ideal graft. And this is a view from the medial portal. You can see the graft is right where the original stump was. We pay a lot of attention to post-op rehab because doing a ACL surgery is as a 60% of the job done. Immediately post-op, we try to avoid flexion attitude of the knee. It can be difficult and painful at times, but otherwise these patients will develop flexion deformity of the knee, which will be difficult to correct. We start the RM at the earliest. Start with the static exercises, and weight bearing depends upon the procedure. If you've done a meniscus repair, then weight bearing is delayed. We completely avoid open chain exercise, tying weight to the leg, because that is most strenuous for the ACL. We emphasize on closed chain exercises and core strengthening, and I can never overemphasize this because it is the most important part of your, especially in sports persons or athletes, because unless and until they develop their core, they will never be as strong as they were before the injury. This is a girl and this is her journey through rehab. Slowly from the firm floor, she goes on to the soft board, and then various exercises. And finally, she could, at the end of 6 months, she could join her gymnastics back. So as we know, with time, our thinking, our executions change. The principles remain the same. The principles of surgery, like biological preservation, right tunnel, remains the same. And then you don't need, whichever device you use, whichever implant you use, whether you use double bundle, single bundle, you are going to get good results. Thank you for listening to me.